Hi guys, welcome back to week 5. This week we're focusing on dermatology in the adult client. Now keep in mind there is no chapter readings really for this particular week, but this particular PowerPoint is very long. It's about 109 slides. So I am going to try to skim through it quickly. A lot of it you can read independently, but I will focus in on the things that are really important in terms of key things you need to know for clinical practice, for your boards, as well as for your exam. Everything in here is obviously important, but there is a lot to the skin. So a lot of it is just making sure you're able to identify what's normal versus abnormal, knowing your skin terminology so that you can document and appropriately assess and reflect that in your documentation when you do document things, especially if it's irregular. So please just make sure to focus in on those things. I do have 2 short videos within the PowerPoint that are helpful in identifying those particular points and just to give you visual reinforcement of the different terminology within dermatology. Okay, so dermatological pearls. Again, what are pearls? Clinical pearls are little tips of advice that are especially important for your clinical practice, as well as to know these important pieces of information because you will need to know them for your boards. So, like I had mentioned before, learn and use the language of dermatology because you must be able to describe skin lesions appropriately. It's important in gathering this information in your HPI, potential causes, potential or patterns of distribution, meaning how you describe what you're seeing on the skin. Is it one-sided? Is it go across the dermatomes? Is it you need to make sure to describe it appropriately. Is it diffuse? Is it central? Make sure you use good words to describe what you're seeing. You need to also document any self-treatment that the patient has used up to this date to try to get, and if they've had any results or success with that. Get used to using measuring lesions in centimeters because depending on the size of the measurement of the lesion will determine what type of lesion it is. There are different classifications which we will go over. If you see a patient with a fever, petechiae, purpura, bullae are present, these are reasons to be concerned and begin looking for systemic and or infectious disorders. Consider collaboration with either infectious disease, you want a dermatological consult, or perhaps a surgical consult if you're looking at an abscess that may need to be drained. So in terms of looking at systemic or infectious disorders, when it comes to dermatological conditions, realize that your skin is just a reflection of what's going on underneath, meaning systemically something's going on and it's starting to bubble up or creep up and reflect that in your skin. So just keep that in mind. If you start to see something, especially if it's diffuse all over, or if it's in one particular area of a limb, for instance, these are indications. What's going on underneath? Look at your blood work, feel the skin, feel the temperature of the skin, feel for your pulses. You want to get all the information you can to make the right clinical diagnosis. Okay, so topical steroids. You want to know this information about topical steroids. Super important facts to know, okay? Corticosteroids are your first line of defense for multiple conditions. We're talking about topical cream kind of steroid treatments. So in terms of the use of emollients or Vaseline type substances that have petroleum jelly in them, like Aquaphor, Eucerin, Lubriderm, all of these type of emollients will enhance the absorption and effectiveness of topical corticosteroids. So just know that if you use them in combination, it'll help them absorb and they'll enhance the actual absorption and effectiveness of the steroid cream. You want to apply topical corticosteroids after hydrating the skin, after a brief shower or bath, which may increase their absorption as well, up to 10-fold. That's a big deal. When somebody is really suffering from whatever dermatological condition they are having, and you tell them that if they put it on after they shower, their treatment cream, their topical corticosteroid, if you tell them to put it on after they get out of the shower and it will increase their absorption and likely work better times 10, that's a big deal to somebody who's really struggling. So make sure you educate your patients on that to help expedite their treatment. You want to learn 1 or 2 choices from each classification of steroids that is typically covered by insurance, especially ones for the face, okay? We use different ones for the face. And medium to high potency topical corticosteroids should not be used on the face or neck because of the potential adverse reactions. So other things to know in terms of topical steroids, you want to avoid steroids in cases of a suspected fungal etiology because sometimes they can worsen the infection. Keep in mind steroids range in potency from class 1 to class 7. Class 1 is the most potent to class 7, which is the least potent. Okay, steroids are most effective when applied within 3 minutes after bathing, like I mentioned before. You want to avoid the steroids on sensitive skin like the face, genitalia, under the breast, inner thighs, because they can absorb more of a topical steroid. So you want to just be very careful with that. Topical steroids that you may want to be conscious of in terms of very high, super high potent ones would be albendazole propionate versus just regular hydrocortisone 1% over the counter, which is your very low potency steroid. Okay, and all of us are very used to using hydrocortisone for any kind of itchy bites, bites from, where you were bitten by any kind of insects. That's when we would typically use your very low potent steroid like hydrocortisone cream or ointment. Okay, so dermatology terminology. Okay, this is really important. If nothing else from this lecture that you don't absorb, make sure you learn this in particular. This will be on your exam for both this class as well as for, you will probably most likely get 1 to 3 questions on dermatological conditions on your boards as well. So really make sure you know this basic knowledge, not just for your boards, but for instance, being able to differentiate a nodule versus a papule versus a vesicle versus a pustule. This is very important, especially when you're documenting in order to maintain a continuity of care, because when the next practitioner reads it, they're going to be able to determine what you're dealing with based on your dermatological terminology. So here we have different pictures to differentiate each particular description. So you have your petechiae, you have your purpura, bolliae, lipoma, nevis. These are all things you need to make sure to be able to differentiate. Now remember, in terms of the anatomy of the skin, your skin has 3 basic layers. You have your epidermis, dermis, and subcutaneous. And that's what this particular diagram is showing you, how these different dermatological conditions manifest within the epidermis or dermis. Other things you want to definitely keep in mind when you're assessing patients in these particular issues, in dermatological issues, is their color of their skin. You may be looking at the same condition, but if it's on a Black person versus someone with light tan skin or olive, dark olive skin, it may manifest differently. So just keep that in mind. For instance, very, very dark, dry skin can appear ashy to gray in color, where skin conditions that are more common in people of African-American backgrounds are like keloids, hyperpigmentation, and traction alopecia, which is due from tight hair braiding, just so you know. Also, in African-Americans, 60% of African-Americans are affected by something called pseudofolliculitis barbae, which is basically like razor burn from when they get shaved. So just keep that in mind. It's really like an inflammation to the skin, and basically the only way to avoid it is to let the hair grow for 3 to 4 weeks. So these are considerations you need to take into consideration in terms of different skin colors when you're assessing the skin. So over here we have nodules, papules. So remember, a papule is differentiated because it's a solid lesion that's less than 5 centimeters in diameter, versus a macule, which is a flat, non-palpable lesion, which is less than 1 centimeter in diameter. An example of a macule would be a freckle. An example of a papule would be a mole, or acne, or small cherry angiomas. Then we have over here on the bottom a vesicle. Now, a vesicle is an elevated superficial skin lesion less than 1 centimeter in diameter filled with Serous fluid, very important to differentiate a vesicle versus a pustule, because a vesicle only has the serous fluid. It's like a herpetic lesion, all right? It looks like a blister with just clear fluid, right? Then you have your pustule, which is also an elevated superficial skin lesion, less than 1 centimeter in diameter. However, it's filled with purulent fluid, as like it would be an example of acne, an acne pustule. Okay, so just keep that in mind, a vesicle versus a pustule. Okay. Okay, so just to really help you differentiate the different skin lesions and describe them, I wanted to play this very short video, which gives a great visual demonstration and definition of the lesions.
Welcome back. So for all dermatology fans, this video basically explains how to describe skin lesions and differentiate between them. We'll start with changing color. So if the lesion is less than 1 centimeter, it's going to be called a macule. And if it's more than 1 centimeter, it's going to be called a patch. And note that macules and patches are both flat. So the only difference is change in color. Next, we have raised lesions. So basically, if the lesion is small, less than 0.5 centimeter, it's going to be called a papule. And if it's large, more than 0.5 centimeter, it's going to be called a plaque. So basically, a papule is a raised lesion of the skin that is less than 0.5 centimeter. And a plaque is a raised lesion of the skin that is more than 0.5 centimeter. Note that papules can infect or have pus inside them, and they're going to be called a pustule if it contains pus inside.
That's would be your acne.
Next, we have nodules and cysts. They're both large fluid sacs. And the only difference between them is that nodules have most of their content in deep layers of the skin, while cysts have most of their content in the superficial layers of the skin. Next, we have vesicles and bulla, and they're both small fluid sacs. Vesicles tend to be larger in number, but smaller in size. Bulla is the opposite, which is larger in size and smaller in number. And one of the most important secondary skin lesions are scaling and crusts. Basically, scaling is thickening of the outer layer of the skin, and crust is dried pus or dried bulla or dried fluid, basically, on top of erosion or on top of the skin. Other secondary lesions, we have fissures and ulcers. They both penetrate the skin to the deep layers. Fissures are usually cut in shape, and ulcers are circular in shape. All right, guys, so that's everything I've got today. I'm not going to go into details about what diseases cause what kind of
So hopefully that was helpful in just giving you a little more definition of how it is that we use these terminology to describe our assessments when we go in and look at skin issues. Okay, so presenting complaints that are pretty typical in the dermatological world are alopecia, which is just basically balding, hair loss and balding, pigment changes. So we start to see discolorations of the skin, pruritus, which is itching, rash, and urticaria. Okay, these are presenting complaints that you'll normally see when it comes to any kind of skin conditions or dermatological conditions. Okay, alopecia. Causes of alopecia or balding examples would be autoimmune, chemotherapy tends to cause hair loss, psychological, whether it's stress and anxiety, and or medications. So we have hormones, anticonvulsants, anticoagulants, oral contraceptives, beta blockers, antimetabolites, antithyroid drugs, and excessive amounts of vitamin A or topical retin-A can all be causes of hair loss. 50% of scalp hair loss can be lost before the loss actually becomes clinically apparent. So if the patient is pulling out the hair, that's a condition, or is the hair loss just on the head? Or is it a loss on the other parts of the body? So these are definitely things you want to ask and assess of your patients. Is the patient pulling out their hair? You may need to ask a caregiver if they're not aware or they're not sure. They don't even realize they're doing it. How much hair is falling out when they're taking a shower? That's another thing. How much hair are they pulling out of the drain? It's a handful, a few strands. Like, what are we talking about? And again, is the hair just falling out on the head, or is it falling out on other parts of the body? Look at their legs. Look at their arms, what's going on with their hair on their arms and legs. The highest risk in the US, 35 million men and 21 million women experience hair loss. That's a lot of people. 40% of men have noticeable hair loss by the age of 35, while 60%, 65% by the age of 60, and 70% by the age of 80, and 80% by the age of 85. Women tend to develop AGA 10 years later than men. That's a relief. Okay, alopecia. So in terms of diagnostics, it depends on the type of alopecia, the patient's history, and presentation. The lab work you may see in this particular condition is we want to look at their CBC, their thyroid, evaluate for any autoimmune disorders, evaluate their testosterone and estrogen levels, as well as their iron. Do we need to do a biopsy? Do we need to do Woods lamps? Woods lamp. That all depends on their symptoms. Are they itchy? Are they red? Are they irritated? Are they flaky? You know, these are all questions you need to really look at. So there are prescriptions to help with hair loss, but the treatment's not that effective. I mean, you want to try to give them as much hope as you can, and if the patient really wants to try, then by all means, there is a small percentage that it does work in some people. So we would prescribe oral corticosteroids, topical immunotherapy, or immunomodulators. I'm sorry, that's the cause of hair loss a lot of the times, I'm sorry. But in terms of prescribing, they have creams, they have injections, there's different options. But again, you know, if you're going to get into treating this, I would suggest you refer them to dermatology, because it does become a specialty. Here we have some different pictures of different patchy hair loss. Women is very thinning up here by the crown. So we have different types of hair loss: scarring alopecia, and non-scarring. Okay, non-scarring is reversible. The regrowth of hair takes several months. There's multiple differentials. And then scarring is usually permanent hair loss. It's non-reversible. Usually it's caused by trauma, you know. Okay, alopecia management. Finasteride daily is approved for the treatment of androgenetic baldness in men only. Teratogenic off-label only in females. All right. There's always the options of minoxidil, which the doses vary for females and males. And then, of course, hair replacements. There's hair plugs, there's weaves, there's wigs, there's hair extensions. There's different options, but they are pricey, and they can sometimes cause further damage to your already existing hair. So just make sure you educate your patients about that. Pigment changes may also many causes also include drug-induced Addison's skin cancers, which we'll talk about later. But pigment changes, meaning the color is changing in your skin. Remember, Michael Jackson had vitiligo, where he had a discoloration of his skin, where his patches of his skin started to lighten and turn white. It may be clinical, differential diagnosis, may be clinical manifestation of diseases, endocrine, genetic, metabolic, nutritional disorders, or malignancy. For instance, Suits-Jeghers syndrome, it's an inherited disorder that presents as dark brown freckles or macules. Remember, a macule is considered a freckle on the lips and in the inside of the mouth on the mucous membranes. It's also associated with multiple GI symptoms, and that's when you definitely want to refer to a GI doctor. We have pigmented tumors such as melanoma, Addison's disease, heavy metal exposure, and side effects of anti-malarial medications. Okay, here's what we were talking about with Michael Jackson, vitiligo, which is a depigmenting disorder. It tends to be genetic, familial, or autoimmune. You get milky white patches as depigmentation occurs, which is the loss of melanocytes. It can be psychologically disabling for dark-skinned patients. Obviously, it really had an effect on Michael. They use the Woods lamp to help diagnose it. Prescriptions are not very effective. I mean, they do have steroid creams, tetracycline. Sometimes they'll use sunlight or phototherapy, laser surgery, or depigmentation. Obviously, there's cosmetic options where you use makeup to balance the skin color. And you definitely want to give a lot of psychological support to these patients, because there's really not a whole lot you can do for them. And it can be extremely noticeable. So here are some pictures of some dark-skinned individuals that, you know, he's darker or she's darker, but you can see how that discoloration is so severe that it's very noticeable. Not such as such a severe difference here, but definitely here. But it's definitely noticeable. Okay, so chloasma and melasma. So chloasma is what they call the mask of pregnancy. This is caused by an increased level of estrogen, progesterone, and melanocyte stimulating hormone during pregnancy. So this is basically they just a darkened areas of the face on a pregnant woman. It just randomly they just develop this dark skin. Sometimes it's on the face, the nipples, the genitalia, the abdomen. You'll get a line, and sometimes it gets worse in the sunlight. So basically, you want to tell the pregnant woman to avoid the sun, use sunscreen. You can use corticosteroids with hydroquinone if necessary. You can use a glycolic acid peel, which helps lighten the skin, microdermabrasion, which helps also even the skin tone, facials, and various laser type treatments are used. But again, in terms of using these particular treatments, this is when you would want to refer out, and the likelihood is you want to wait till after they have the baby. And melasma is hyperpigmentation regardless of pregnancy status. So chloasma is when you are pregnant and you get this changing your color of your skin, versus melasma where you get this hyperpigmentation and you could be pregnant or not. It could be from sun and hormones. Okay, pruritus, just basically itching of the skin. It's a very common skin complaint. A lot of the times it's just caused by xerosis, dry skin. Again, remember your dermatological vocabulary. Xerosis is another word, very important. It's just dry skin versus pruritus, which is itching skin. Very common in the older adults, sometimes younger, depending on what kind of products they're using on their skin. You want to avoid harsh soaps, deodorants. Hot water can be very drying. Remember, when you're getting these common inflammatory type symptoms from patients, you want to immediately start with the basics. Let's look at your products you're using on your skin. Are we using a lot of excessive perfumes, dyes, creams with a lot of chemicals in them? If so, we want to talk to the patient about considering changing their laundry detergent to hypoallergenic products with fragrance-free, limited chemicals. Talk about the chemicals they're using in their house. Do they have a lot of air fresheners, a lot of Febreze use type products where they're spraying things on their sheets and their couches? These are all things that can definitely lead to dermatological conditions. So always start with your basic stuff with your patients. Limit the creams, limit the perfumes, limit any products that have perfumes or chemicals in them. Okay. Obviously, if your pruritic rash or your itching does not respond to basic treatment, then we want to go further and work up for systemic diseases in order to make sure we're getting an appropriate differential diagnoses. So in terms of systemic diseases, we're looking at our CBC with differential ESR. We'll want to look at our blood sugar. Are we on the verge of diabetes? Do we have diabetes? We want to look at liver and renal function tests. A lot of the times, liver and renal function these diseases can manifest with itching skin, thyroid profile, and of course a viral hepatitis profile. If we're getting any pruritus in our anus or anal pruritus, you want to examine for any kind of external hemorrhoids and check for your stool for ova and parasites. If you are concerned that we have a pinworm infestation, that's when you're going to do the Scotch tape test. Okay, so management of pruritus, just like I said, avoid strong soaps, perfume, long hot showers, use tepid water, be very careful in hot tubs as well as pools. The chemicals and chlorine in these particular pools are breeding grounds for bacteria, as well as the chemicals being very caustic to certain people who have sensitive skin. You want to use Eucerin, Lubriderm. These are very hypoallergenic type lotions that can be very helpful in moisturizing the skin. You want to avoid gels that are alcohol based, especially if we already have dry skin, because they can cause more dryness. Okay, so in terms of treating pruritus or any excessive itching, you can do lidocaine and immunomodulators. Okay. Okay, urticaria or sudden generalized eruption of pale, wheals, or papules associated with severe itching. This is like hives. Okay, that's a concern. And then we have angioedema. which is urticaria, edema of the dermis and subcutaneous tissues. So angioedema may be life-threatening, okay? It's definitely an anaphylaxis reaction. So if you see sudden severe itching, especially with any kind of patchiness, especially if it starts to develop over the chest, near the throat, in the face, swelling of the eye, swelling of the lips, these are immediate. Call 911, get your defibrillator, get ready to do CPR, because we are always concerned that the airway will start to close, especially if it's an allergic reaction from any kind of food or medications. We want to immediately call 911. So these kind of hives you watch, especially on children. So remember what we talked about in terms of the manifestation of these dermatological conditions on different colored skin. So here on the left, we have our dark colored skin, and urticaria is on there, versus the urticaria on the light colored skin on this Caucasian over here. There's a big difference in how these two different things manifest, but they are the same condition. So just be conscious of that and get used to seeing these types of things and being able to recognize them, even despite the different race of color you're looking at on the skin. So again, you're looking at this diffuse patchiness. It's on both sides. And you're looking at that kind of little slightly raised elevation. You can't really see in this picture, but the likelihood is it does have a red, kind of an erythematous red kind of look to it, as it does here. Okay, dermatological procedures. Here's the Woods lamp. The Woods lamp is used to diagnose quite a bit of things, specifically like fungal type things and bacterial. So it's a small held lamp that uses black light or ultraviolet and transillumination to detect bacterial or fungal skin infections. It's really helpful in identifying cutaneous disorders. So it can diagnose dermatosis in intertriginous areas, tinea versicolor, scalp lesions, skin pigment disorders such as vitiligo. A lot of the times vitiligo and tinea versicolor can be confused because they both cause discoloration of the skin. Diagnosis of burrows and scabies infestations, blisters and punctuate erosions on dorsum of hands and forearms. And it's also used to detect corneal abrasions. They use it on pets in the vet office. So here's an example of what it looks like when they light up the skin. So it's like an ultraviolet light. They just put it against the skin or near the skin and it lights up, and fungal infections will glow and light up as like white to yellow in color. Pseudomonas is more yellow-green and Corynebacterium is more coral red. So you're looking for the fluorescence or change in the color, and it's mostly used for fungal detection. See right here, you can see that. Okay, so here's the KOH preparation. It's a number 15 blade. You want to scrape from the leading edge of the lesion. You're just scraping it very gently to get a nice little layer of the scrapings, and you're going to get it on the slide. You put some of the KOH solution on the slide, apply a cover slip, and then it goes right under the microscope. And you're looking for branching appearance, which is the result of a fungal lesion. And that's what it looks like. But the likelihood is you won't be doing this, okay? But this, you just should know what the diagnostics entail. So you know what to order and what we're looking for when we do order these things. Okay, next we're getting into parasitic infections. We have scabies. It's easily missed. The presentation can vary in intensity. The likelihood is once you see it, you'll recognize it after that one once again. But until you see it, it's hard to differentiate it. Most of the time the itching is at night. You want to look at web spaces between the fingers and the waistline. And you also want to make sure, you remember that your permethrin is your first line of treatment. You want to treat the patient's context, treat the environment. It's very, very contagious. We would see this in when I saw this, really was when I was working as a school nurse. I saw it in the children of immigrant families who were living in small spaces, sharing beds, sharing, pretty much everything, particularly linens and clothes, and that can lead to this being a contagious thing to basically all the sisters and brothers in the family. So the big thing you want to do is educate the patient and their caregivers on the importance of cleanliness. So washing the linens, hot water, bleach, especially no sharing of towels. You want to make sure everybody's clothes are washed in hot water and bleach if you can, and you don't want to return until it's gone. So here's what it looks like. See in between the webbing of the fingers, you get these little bites in there, and these little, it's uncomfortable, and it's very, you'll see a lot of excoriation from the scratching. And here again, just to differentiate on a dark-skinned individual, what it looks like compared to a Caucasian. So here on the light skin, it's much more red and irritated and angry looking, versus here it's actually differentiates in darker colors. So just keep in mind, but again, you're looking in those webbed areas of the fingers and the toes. That's where you're really going to differentiate it. Okay, lice. Woof, lice is also very contagious. Also something you're seeing in patients who live in close quarters with a lot of people in their homes, and are not exactly that hygienic in terms of their cleanliness. So lice is usually in the hair. It can be in the eyelashes as well. It can be in the pubic area as well. But possible pubic lice, also you want to screen for STDs because that's also known as crabs. Eyelid infestation in children, you may want to consider sexual abuse. And you can also use the Woods lamp because the live nits live and appear like pearl-like fluorescence. Basically, you comb through the hair of the suspected person if they're having a lot of itching. You use gloves and you use Q-tips, like the end of a wooden Q-tip, and you separate the hair follicles just to see if you see any little white flakes. And if you see them consistently throughout the hair, you know you're dealing with lice. You have to treat the patient immediately with lice-killing shampoos, manual delousing and nit removal. It takes hours. There are actually, when I was working in New York in Tarrytown, they actually had a few people who all they did was specialize in treating lice. And it would be basically like a mom who's used to dealing with lice who would come to your house and spend hours getting the lice out with this particular shampoo and using a nit removal comb. It's not fun. You don't want to get it. The minute it's found, you want to treat it, and you want to treat everyone in the house. You want to remember also is even though that the lice only live on humans, you still want to treat the environment. Wash the bedclothes. You want to vacuum. You don't want to take any chances with this. So here's what it looks like. Those little white flakes, that's that. I've never seen it in the lashes. That's pretty rare, but if you do see that as well as in the hair, you know we have a problem. You do want to suspect abuse. And there's pubic lice. Okay, sea lice. It's not the same as hair lice. It's just basically a hypersensitivity reaction to a larval form of jellyfish. Remember, jellyfish are clear. So people who swim in the ocean a lot can't always see that there's jellyfish nearby and may actually be exposed to the larvae of jellyfish. It's also known as sea bather's eruption. You want to make sure, obviously, to wash that bathing suit in hot water with soap. And then you want to apply diluted vinegar or rubbing alcohol to deneutralize the larvae. And you treat it symptomatically. It may require oral steroids if it becomes very inflamed and painful, but it does go away after a few weeks. So swimmer's itch, also called cercarial dermatitis. It's a reaction to microscopic parasites from birds and mammals living in infecting water. It often comes from snails. If you do see this, you want to definitely notify your local health department and follow the CDC guidelines, because they do have to find out where this person was swimming so that hopefully they can avoid getting, other people can avoid getting this, because it does infect, specific areas sometimes. And it's pruritic and it's erythematous papules, so little raised bumps that are itchy. Okay, bacterial infections. So impetigo, it's seen frequently in your pediatric patients a lot of the times, especially if they have these little runny noses with crusty stuff around their noses and the sides of their mouths. Think impetigo. It's usually gram-positive for staph or strep. It is highly contagious, so make sure everybody's washing their hands, using lots of hand sanitizer, soap and water, getting rid of any kind of snotty shirts or anything that the patient or the little one might have wiped their nose on, sleeves. You want to just constantly be changing their clothes, pillowcases, towels, toothbrushes, all those things need to be changed, cleaned, washed frequently. Bullous form are common. So bullous formation is common. So meaning like those blisters that pop and produce that crusty drainage that turns into the honey crusted lesions. Again, it's around the mouth, the nose. You want to make sure that you prescribe antibiotics to cover both staph and GABHS. MRSA is cited as the causative agent for nearly 80% of all of the community-acquired staphylococcal skin and soft tissue infections. So that's a high percentage rate. Penicillin therapy is recommended for streptococcal impetigo. So you could do topical and oral treatments. You can use a Bactroban cream or Bactroban ointment. You want to make sure you remove the crust with water, a little warm washcloth, and just gently wipe at it to just try to get those crusts and all that, stuff from sitting on the skin. So really you want to use the oral therapy or the systemic antibiotics when you have systemic symptoms, meaning we have a fever or a high fever, we have a large area of skin that's involved, or it occurs within the context of athletic teams or childcare or family clusters. That's when we need to consider systemic antibiotics. So here's the impetigo. Again, that honey crusted lesions, it goes around the nose, around the mouth. You want to try to wash all that stuff off, slough it off with a warm washcloth and use that ointment afterwards. Again, lots of hand washing. Just really try to keep things nice and clean and sanitized, especially anything that the patient may be using. Folliculitis is basically just an infection at the hair follicles, usually caused by Staphylococcus aureus. It's common in all ages. It can be anywhere, especially any areas of shaving. So you want to be careful because sometimes people will think, especially if they shave their genital area, that they may have an STD when in fact it could just be a folliculitis, like some kind of skin reaction, whether they shaved too soon, too close, after they went swimming in a pool, in the ocean. Anything that could have possibly exposed those open pores after they just shaved to any kind of bacteria. So make sure you're educating patients, especially anybody who shaves, to make sure to change their razors quite often and to shave in one direction and to use products that will help keep their shave clean and prevent them from nicking at themselves. Again, the African Americans tend to get pseudofolliculitis barbae, which again is really like a severe form of shaving bumps. So the way to prevent that is just to have them not shave. And if you're seeing folliculitis and you're suspecting fungal, it's a fungal infection or a fungal cause, you can do the fungal culture or scraping with the KOH. You want to instruct on proper technique of cleaning, shaving, preventing ingrown hairs and infection. You can do a culture and sensitivity and grand stain if there is a pustule with drainage that you're concerned about. Remember, really with these types of things, whether any dermatological condition, you're looking at that drainage, the drainage and the surrounding area. Are we talking infection? Are we talking cellulitis? Are we talking inflammation? How is that drainage? Is it green? Is it gooey? Or is it clear and white? And the likelihood is it's going to clear up in a few days. Or are we looking at a lot of redness, warmth around the area, pain, discomfort? Then we're concerned about a deeper systemic infection. So here's folliculitis, hot tub folliculitis. Okay, again, so what does that even mean? So those are open pores. Somebody went into a hot tub, was exposed to all the germs that are breeded and bacteria that breed in hot tubs because of the temperature of the hot tub, that hot water where bacteria loves to breed. They went in, maybe they just recently shaved and they developed this folliculitis. Their pores got infected by the Pseudomonas infection, and now here they are inflamed. We need to disinfect the pool, the hot tub, and other bathing sources, and we need to notify the CDC because they have guidelines around the way you disinfect these particular things. And if they're not being followed, it can lead to this. And this is not good. We don't want people to see an influx of patients with folliculitis just because somebody didn't disinfect a pool correctly. It is self-limiting, but it is self-limiting. It'll go away in a few days usually. You don't want to usually prescribe because it can weaken. There's usually no oral prescription, but you can use weak acidic acid compresses to help relieve it. If they really need it, if they're immunocompromised or it becomes a consistent infection or persistent infection, then we'll consider Cipro. Again, here's folliculitis. Looks like teeny mini pimples. And this is folliculitis barbae. This is what you would see sometimes in an African American's beard. Caucasians can get this too, but it's much more common in African Americans, where they develop these painful bumps. It really can be very painful. So you just want to tell the patient to just keep their skin clean and dry and avoid shaving. Okay, so then we have furnicles and carbuncles. Furnicles are more known as boils, and they involve the hair follicle. Again, it's usually a localized infection, and it's papular and pustular, often caused by staph. You want to use warm compresses to drain them, and you want to collaborate as needed depending upon the location and the severity. So a furnicle is like one boil or one single boil versus a cluster of boils, which is less common, and that would be your carbuncles. Okay, when you're dealing with a cluster of boils, you tend to think more of a systemic issue is going on, especially if there's a fever. This is when you want to collaborate, you want to get infectious disease involved, you want to look at blood work, you really want to figure out what's going on. You may need to drain it, drain the carbuncle or the boil, the furnicle, depending on how deep it is. If you do end up incising it with a scalpel, you just cut it, drain it, and then you pack it to allow it to heal quickly. And you just want to educate the patient. So here is a furnicle versus furnicles versus a carbuncle. Okay, so these are big difference. So your furnicle is just one versus a cluster versus above the skin, the carbuncle. And here you would, likelihood is you would need to drain this, put a little slice in it, drain it out, and then pack it. A lot of times we pack it with iodoform packing strip or packing gauze. Okay, hydradentitis suppurativa. You don't see this very often, but when you do see it, you won't forget it. I am a wound consultant, and this is a very chronic condition that I see very rarely, but when I see it, I know this patient is basically going to be mine going forward because this tends to come and go and not really go, but just kind of stay in remission for a short amount of time and then come back. And basically, it's a disease of your apocrine glands, and it's like you get these boils or abscesses or comedones that tend to drain, and it's usually in like your underarms, your groin, and your anal area. And it is very consistently that. It's very textbook. It's described exactly how it presents. It can actually, in this particular classification, they wrote puberty to 40s and females more than males. I will say I've seen the elderly quite a bit. Once you get it in your young age and it doesn't go away, the likelihood is it will continue on as you get older. It is painful, it is relapsing, and it is chronic. And it's basically like these abscesses they just get in their armpits, in their anal area, that just continually are like boils that are present that drain. So we have them bathe with Hibiclens to try to really keep the areas as clean as possible. And then we pack, if there's open areas, we apply calcium alginate in there to help dry it up and keep it from hopefully getting infected. And then we cover it with bordered gauze to catch any drainage. But these dressings have to be changed daily because usually there is a bit of drainage, depending on the severity of it. So obviously the treatment plan should include medical management first. However, depending on the severity of the abscesses, that's when you would need to consider a surgical consult. Local hygiene and ordinary hygiene. Hygiene, I will tell you, for the patients that I've seen with this particular condition, is one of their biggest issues. They don't seem to be the cleanest, or the places they're living in don't facilitate a clean environment. So, when you're seeing them in the nursing home, if the nursing home doesn't have the best cleanliness to assist the patient in their own self-cleanliness, then obviously you're going to lead to a recurrent infection. Weight reduction in patients who are obese. Obviously, if you have obese patients with a lot of skin folds and areas for, this type of condition to create lots of moist areas that, where boils like to develop, then obviously you're going to have more of an issue. So if you can get these patients to lose weight, that'll definitely help this condition. And then another big thing is smoking. Smoking makes this worse. And I will say, one of the patients I have who has this particular condition, disease, one of the biggest factors I feel that is making it so consistently constant is the fact that he smokes so much. But he doesn't want to quit. So this is what he has to live with. So for the particular treatment for hydrogenditis, you want to use application of warm compresses with sodium chloride or boro solution. You want to wear loose fitting clothing. You want to have laser hair removal if they can, cessation of cigarette smoking, and anti-inflammatory or anti-androgen therapy such as oral or topical antibiotics. So a lot of the times these patients will go on and off antibiotics periodically to help not get rid of it, so to speak, but lessen the severity of the drainage and the condition of the abscesses. In terms of applying warm compresses, that's not always practical. Warm showers with the use of the Hibiclens, that is practical. So a couple of showers a day can sometimes be good for them. So here's an example. I'm going to be honest with you, this is a very mild case. The cases that I see are pretty severe. You'll see multiple abscesses in the armpits and a lot of drainage, as well as sometimes odor, because if they're not showering on top of getting this drainage, sometimes it can be, it can really smell. This one in particular will likely need an IND. Okay, cellulitis. So infection of the dermis and subcutaneous. Usually with a cellulitis, it's going to be red, it's going to be warm, it's going to be swollen. So redness, warmth, and swelling is never a good sign. You immediately want to get that looked at and decide what you're going to do in terms of differential diagnosis and treatment. It's common in the legs. Obviously, when we see a cellulitis and we're seeing warmth, redness, and swelling, we're also concerned about a DVT. So you want to differentiate, is it a DVT versus a cellulitis? That could be a differential diagnosis, and you want to treat accordingly. It could also be a secondary infection. So a lot of the times you'll have a surgery and we'll get a secondary cellulitis to the surgical area. Again, very important that you recognize it and treat it as needed. You want to note the size, check for lymphadenopathy, meaning are the lymph nodes near the surrounding area swollen? Do you feel any crepitus? Do you see any bullae, any blistering, any drainage? Is there any systemic symptoms? Are they getting a fever? Are they tired? Are they having pain? Are they tachycardic? These are all systemic signs of infection. You want to watch for rapid progression of the necroticizing flesh-eating. So rapid progression meaning you want to keep an eye on the area. So a lot of the times when you see a cellulitis in a patient, you want to marcate the area of redness. So that way, if it starts to spread, whether it's red or dark, you can see the progression of the spread so we know what's happening. So make sure you get a nice marker or pen and you really mark the area so people, the next practitioner, can really make sure that they're watching to see if there's any rapid progression of the spread of the cellulitis. Because remember, we're worrying about any kind of flesh-eating bacteria. Comorbidities may complicate it. Obviously, if they're diabetic, immunocompromised, you want to collaborate as needed. Do we need debridement? Do we need IV antibiotics? Are we septic? These are all things you want to get your fellow practitioners involved to really pinpoint what's going on with this patient. Remember, you don't know what you don't know. And in these particular cases, you want to be extremely careful and methodical about making sure you're treating this patient appropriately so that they don't become septic or they don't, God forbid, need to have an amputation because of the situation. So if it's an uncomplicated cellulitis, we usually treat with cephalexin or although you may see augmentin, macrolides used as needed depending on the patient. Okay, so you want to culture any drainage and adjust the antibiotics depending on what you find. But you want to start your antibiotic right away. You don't wait for the culture, but if you need to change the antibiotic based on the results of the culture later, you can and will. Again, mark the area and teach the patient to watch for the spread, like looking at that area you marked and let them know to let you know if they see that the area of redness is spreading, okay? Remember always to educate your patient to be their own best advocate, all right? Because nobody's gonna advocate better for them than themselves, as long as they can. All right. Same thing for teaching their caregivers. You want to make sure they rest and follow up in 1 to 2 days if it gets any worse. We're checking their CBC. And like I said, we're collaborating. We're referring to the emergency department if it gets any worse. And we're educating the patient when they need to return if there is any worsening symptoms. So here's some examples of cellulitis. And you see this marcation here. They actually drew the line of where the redness was starting so that if the redness started to creep over that line, we would know immediately that the infection is getting worse and spreading. Here's a cellulitis area. There's something there going on. This is pretty dark. Again, a darker skinned person, you're not going to see it as much, the redness, but you will see the marcated areas of the discoloration. So just keep that in mind. Here is a nice cellulitis, probably a bad pimple or something that got some bacteria in it and led to that. Again, this is this is very close to the oral airway. So you want to be very careful with those types of cellulitises. Make sure they get treated and responded quickly. So erysipelas, this is a superficial form of cellulitis, may occur after strep infection. It's well demarcated, slightly raised border, orange peel feel to the skin. It's often seen in pediatrics. The likelihood is they will need to be hospitalized with IV antibiotics. It does look very close to cellulitis, but it does have that orange peel texture. So just keep in mind that that kind of differentiates it. Okay, warts. Warts are usually associated with viral human papillomavirus. They could be plantar, flat, or verruca. They may be self-limiting. They can occur anywhere on the hands, feet, trunk, genitalia, and the face. They're easier to diagnose. They're fleshy, firm, raised, irregular. They're not normally painful. They could be itchy, but not normally. Treatment really depends on the location and how extensive they are. They do use something called duct tape on warts where they'll wrap, like if it's on a finger, they'll wrap the duct tape around the finger and leave it on for a certain amount of time and then keep changing it. And eventually the wart does disappear. You could do that. I mean, that's a pretty mild way of treating it, I suppose. There is ketorolalytics, which is OTC, over the counter. Retin-A, cryosurgery, there's injection, and then of course they can scrape them off. But again, it all depends on where they are and how severe they are. And if they're really bothering the patient. I mean, so here's some different warts. You've got your plantar warts. There's a wart, there's a wart. They don't always look like this though. Warts, these are pretty accentuated pictures of warts. Sometimes warts are they're not so large. They could be a little smaller and just, very benign looking. Okay, so again, we want to differentiate cellulitis or DVT, like we mentioned before. If it's on the legs, like I said, both can be very similar in their assessments: red, warm, and swollen, and painful. They can all be very painful. Consider risk factors for both. So you want to find out what's going on with your patient, what is their historical background of how whatever they have developed, and that might give you some more information as to which is which. We want to look at the systemic pieces: fever, lymphadenopathy, crepitus, bullae, all point to infection. Okay, DVTs, those tend to be sharp, stabbing pains that are sudden, but again, just really look at your differentials assessments and to help you guide you. Okay, dermatitis. So irritant contact dermatitis. So you're going to see a lot of dermatitis. It could be for random things. It could be very, you could easily pick it up, like the cause, or it could just be a random thing that they were exposed to. You have no idea, and then it just disappears. But these are the different things you need to make sure you're looking at. You want to do a thorough HPI where you're looking again at their soaps, their lotions, their creams, what they might have been exposed to, if they were exposed to any kind of chemicals in their workplace. Is it itchy? Does it burn? Look at the distribution of where it's spread out on their particular limb or on their body part. How is the spread of it? Like, does it look like something was spilled on their hand? Is it pinpoint? Is it on one particular finger? This will probably guide you as to the causative agent that led to it. Okay, again, noting dark skin versus light skin. So the dark skin patient, you want to notice the color and the pattern. It's around the waist here. So look at this contact dermatitis or this dermatitis. It's a discoloration around the waist, which is probably being caused by something that's rubbing against the skin. Well, what could be rubbing against the skin? It's right here in this area, his belt, his pants, some kind of detergent he used on his pants, something in his underwear. Is it a new fabric that he used? You know, did he use a new lotion in this area? You know, did he try to shave his skin in this area? You know, there's all kinds of reasons why this could have happened, but you know it's in this area, so that helps you differentiate what the causes could be. Again, here we have this particular area where they developed the dermatitis. You know, the next thing is, what are you using to clean the toilet seat? Because it's obviously something from the toilet seat, right? Again, where is the point, the pattern of the dermatitis? Look, she's wearing flip-flops. Obviously something in her sandals is causing a reaction to her skin. Is it plastic? She might be allergic to the plastic in the flip-flop. Okay, allergic contact dermatitis. You know, its initial sensitization is within 10 to 15 days. We could get recurrent eruptions in 8 to 48 hours. A lot of the times this is just caused by jewelry that's cheap, or not cheap jewelry, but jewelry that is made of nickel. So a lot of the times if you have younger teens, they like to wear this type of jewelry. It's cheap. You can get it at Claire's. And these types of jewelry, though, can sometimes cause an allergic contact dermatitis. Yeah. So we can use a little neomycin or bacitracin, and the likelihood is they're just not going to be able to wear this type of jewelry. You want to just educate these patients on buying jewelry that is hypoallergenic, or real gold, or sterling silver. Okay, other types of dermatitis. Poison ivy, very common. 1, 2, 3, poison ivy. That's when you see those plants with those 3 leaves that have that sticky sheen on them. You know you're going to be concerned about poison ivy. This tends to be more up north in the New England areas. You'll see it more in the warm months when people are outside hiking, running around in the grass. Sometimes poison ivy or poison sumac, all of them, they just creep up on you. A lot of people don't know how to differentiate them. But again, there's an oil in the plant that's sticky, that adheres to the skin. It can be transported by different things like pets or garden tools, or even a hose. If somebody else touches it and leaves that oil on that particular inanimate object, you can get it. So just keep that in mind. You want to make sure when somebody's using garden tools or any kind of stuff in the garden, you want to make sure that stuff is cleaned off really well. It presents as linear vesicles on erythematous base, and it's pruritic. So all that means is you get these bubbly blisters, little blisters, clear vesicles.
It's 4 o'clock.
And very itchy, and becomes red, and it can be swollen. It can be, some people are severely allergic to it. I am in particular very allergic to poison ivy. The minute I get it, I have to start on steroids because I become so inflamed from it, as well as oral antihistamines. You can use calamine lotion once the blisters have dried up, and that will help a lot with the itching. Like I said, in some cases, it can be very severe, and you want to use an oral steroid taper because the lesions become extensive, or you just have difficulty functioning because of where the lesions are. It can spread to all over your body. It's really awful. So if a patient presents with this, if they've never had a history of it, or they have had a history of it, you just really want to make sure you educate them on what to do, how to report it, or when to report if it's getting worse, and what to do. Again, this is another one of those things where cleanliness is really important, because it does spread, the oil spreads, and if the patient has oozing vesicles, that the oil in the vesicles can also cause more the poison ivy to spread. So again, washing their hands, soap and water, cleaning the sheets, washing the towels, not sharing anything, just being very conscientious of where the patient sits or where they could rub up against, and just keeping things nice and clean. Obviously, if they get the poison ivy in their eye, they need to be referred to ophthalmology. So it's a linear pattern of vesicles. Remember those little vesicles, those little bumps that have like they look like teeny little blisters. 1, 2, 3, poison ivy. So this is what it's hard to differentiate. Honestly, these pictures aren't the best of what poison ivy actually looks like. This is probably the best one. But poison sumac, poison oak, they're all pretty similar in their presentation. They're all itchy, edematous, you get these vesicles. So you can do oatmeal baths and soaps. Aveeno makes great products for that, especially for itchy skin. They do have this product called TechNu that's over the counter that you can use, which will actually help prevent it from spread because it washes off the plant oils. Remember that this particular poison ivy, just like any other dermatological condition, can develop into a secondary infection if it is not treated, especially if it develops into a cellulitis from scratching. Okay, next we're talking about an atopic dermatitis, also known as eczema. I'm sure many of you have seen this. It's very common. A lot of the times it can be caused by allergens or irritants. Even stress can sometimes provoke eczema. It can be severe in some cases. It's manifested by dry, pruritic lichenification, erythematous discolorations with scaling, bleeding, and oozing. You want to do a skin culture, and you want to prescribe emollients, and you want to make sure they're avoiding any irritants or allergens, any kind of products, like I said before, with fragrances or chemicals that could cause any further irritation. We want to give them some hydrocortisone cream, and if it gets really bad, we're going to do the steroid tapers over a 2-week period, as well as antihistamines. Again, here's some eczema. It's just that dry, scaly, scratchy skin. Here's some eczema on a baby's face, but we do get it in patches. And again, you're looking at it from the different skin colors. So lighter skin, it's more red and raised. On the darker skin, it tends to just look darker in color, but you still get those raised dry patches. Okay, seborrheic dermatitis may be associated with other chronic conditions like HIV, AIDS, and Parkinson's. It's common, it's chronic, and it does have remissions and exacerbations. And usually it's a pink scaling, typically scalp and face type presentation. It's asymptomatic, but it may be pruritic or itchy, and it's definitely aggravated by perspiration. Really, it's on your scalp, and the best thing you can treat it with is dandruff shampoo, like Selsun Blue or your selenium sulfide or ketoconazole. Okay, so seborrheic dermatitis on the face, this is where it would be. Dark skin hairline would be like back here. Again, it's kind of a patchy looking, scaly looking thing. And then on tan skin, you get your irritation up here. Again, it's like kind of patchy and red. Okay, so dermatitis tips in terms of your assessment, you're looking for the distribution and the patterns. Is the rash around the waistband and clearly demarcated lines? Is it a possible allergy to the material in the clothing, bleach in the clothing, or is it an infestation in the clothing? And then costume jewelry often contains nickel. So costume jewelry being fake jewelry, like it doesn't have any real substances in it, leading to more likelihood of dermatitis on the skin. So you want to look for a rash around the neck, on the ears, on the wrists, anywhere the jewelry sits. If you're getting a dark band or a pruritic band, you know the likelihood is it's caused by the jewelry, the nickel in the jewelry. So you want to avoid any jewelry that contains nickel, and really focus on hypoallergenic jewelry or jewelry that is, gold or silver. Okay, so in terms of questions you're asking the patient about their possibility of the cause of their dermatitis, you want to inquire if they've had any new medications, started any new drugs, started using any new cleansers, soaps, shampoos, or change in their laundry detergent, as well as perfumes. Okay, many times cannot determine the offending agent at the time of the visit. So sometimes it's going to take a few inquiries at each follow-up visit to really pinpoint what the offending agent might be, because the patient may not even realize. Do they get any tingling or funny feelings in their mouth, their tongue, difficulty swallowing, or breathing? You want to make sure you're documenting this, that the patient denies any kind of change in their swallowing, any throat closing, any itchy throat, because this is very important in terms of clarifying that the dermatitis or the allergen is not affecting their respiratory status. You want to look in their mouth as well and just document that you did not see any swelling of the tongue or looking any evidence of a systemic reaction. Remember, these are pertinent negatives. So you don't always have to diagnose pertinent negative things or things that are the patient answers no to. But in this particular case, you want to make sure that it is clear that you actually assess for these particular um, assessment factors in the dermatitis inquiry. Okay, so we often use topical corticosteroids for inflammation and pruritus. Remember, we talked about the different classes of steroids and their potency. You may need to use oral corticosteroids and just make sure you do it in a tapering dose over 2 to 3 weeks. And the antihistamines really help more for sleep. It doesn't help as much with the itching as it does just to help the patient sleep so that they can sleep through the itching. Don't be surprised if you find that even though they're sleeping, they're still scratching themselves during the night. If this is the case, you want to make sure that the patient is trimming their fingernails very short and possibly wearing mittens or socks over their hands at night so they don't scratch themselves while they're sleeping. Okay, so we do have drug eruption dermatitis where they get an overall generalized rash, from a new drug. It can occur up to 2 weeks after starting any new drug, and it may present as a morphologic variation. So just keep in mind, any of these particular variations in their reactions might be a reaction to a new drug. So keep in mind when you're doing an HPI on the patient, you want to find out any new medications they may have started within the last 2 weeks. Urticaria is highly suggestive of a drug reaction, so keep that in mind. Okay, so drug reaction treatment. Here's one of your worst case drug reactions. It's called drug-induced vasculitis, and you literally lose circulation to a particular part of your body, which could lead to losing that particular part of your body. So you want to make sure you do your drug reaction treatment immediately in that you discontinue the medication. You record the allergy in the record. You treat the patient symptomatically, provide hydration, cool compresses, tepid baths, cooling lotions, oral corticosteroids, epi sub-Q as needed. Definitely have an EpiPen available for your patients with allergies, and you want to encourage med alert bracelets for any patient who have severe drug reactions so they never are prescribed accidentally that drug again. Okay, rosacea, pretty common. It's usually seen in ages 30 to 50. You get the butterfly rash on the face. It often coexists with acne vulgaris. However, there's no comedones found in rosacea. So it's more just the redness, that is usually precipitated by trigger factors. So alcohol, hot fluids, spicy fluids, people with rosacea are also extremely sensitive to the sun. So the minute they go in the sun, the flare up of the redness will start. There are oral antibiotics and topical creams you can use to diffuse it, as well as laser treatments. But the biggest factor in rosacea is really just avoiding those trigger factors to prevent it from worsening. A lot of the times you'll see rosacea in lupus. Acne, this is the most common skin condition in the US. It peaks around ages 12 to 25 with a peak at age 15. It's usually greater in females than males. And 85% of individuals experience some form of acne in their lifetime. Most of the time it's teenagers, especially with those hormonal changes and poor dietary choices. That's when we tend to see a lot of the acne. It's an inflammatory disorder of the sebaceous gland and accompanying hair follicles. Again, it's mostly related to your hormonal influences. So as our teenagers start to develop, you'll start to see more of a breakout. We definitely categorize acne into mild, moderate, and severe. And you can see the prescriptions, the treatments for acne on table 17.1, but we'll really get more into that in FNP2. Okay, viral. So we have herpes, HSV1, HSV2, and we know the triggers. They're listed over here, and the treatment is usually antiviral medications. They can be prescribed PRN or daily as needed for prophylactically to prevent outbreaks. So we have herpes simplex virus, which is 1 to 26 days post-exposure, generally the most severe outbreak they will have. Usually it lies dormant, and then you have your recurrent phase where the virus reactivates. In the virus, when it's activated, the vesicles are present and they're open. Usually it's on the lips, or if you get it in, this is oral, or you could have it on your genitalia. So primary infection, we want to treat with acyclovir or valcyclovir. Recurrently, if it's recurrent herpes labialis, you want to try to do it with acyclovir and valcyclovir to suppress it every 2 months. And if it's, again, you're basically treating it with the same drug. It's just depending on how often the patient is getting the recurrent genital infections. This can be very painful. Obviously, it affects their sexual partners, whether they can have sex with them or not. So you want to make sure the partner is getting treated and tested and really do a lot of education. And of course, if you have a pregnant woman, that's a whole nother concern, and you need to provide education as well as further follow-up testing for them. Thank you. All right, fungal and dermatophytosis. So tinea, there are a lot of different types of tinea, and all of it is just basically fungal. So we have tinea capitis, which is on the scalp, ringworm of the scalp. We have tinea corporis, which is body ringworm of the body. We have tinea cruris, which is jock itch. We have tinea pedis, which is athlete's foot, or and then we have tinea manum, which is tinea of the hands, and tinea versicolor and pityriasis versicolor, which tends to be more on the back, diffuse fungal rash on the back, but it can extend to the front. You want to inquire about contact with infected family or pets, especially when it comes to ringworm. And basically, you're going to note scaling with pink erythematous edges with a central clearing, and some may be annular. Some may be more inflammatory. Basically, you're going to do skin scrapings, cultures, and the wood lamp to really make your differential diagnoses. So here's a bunch of different pictures of what it looks like. Again, we're differentiating between dark skin and light skin. We have your tinea capitis of the scalp right here. It's more patchy, but this is a dark skinned male or person, so it looks more white here. Then we have the tinea capitis on a tan skin, which on this one, on the tan skin, the area looks more grayish in color, but still, it still has the same patchwork look. Number 3 here, we have tinea manum, which is just basically tinea on the hands, a fungal area on the hands. This is more on the just the tinea on the light skin corporis, so it's tinea corporis, but this is on the dark skin versus the light skin. Again, it's just this patchy, diffuse thing going on with the irregular borders. That's how you know it's tinea. Here's tinea onychomycosis. I'm sorry. So this is basically nail fungus, fingernail fungus. Then we have tinea cruris, which is jock itch on the light skin. This is more on the baby, like a diaper rash. Very similar. Here, number 8, we have tinea pedis, and you want to look at your macerated skin around it. And again, onychomycosis, this is fungal toenail fungus. So onychomycosis is fingernail fungus, and onychomycosis is toenail fungus. Well, it's all the same, I guess. So it's just all nail. So anyway, nail fungus is here. I thought we could differentiate those two, but anyway. So for each tinea has a specific treatment. So you want to look at your table to really differentiate which treatment is which, but it's often topical with azole class drugs or other topical antifungals. You sometimes will use an oral systemic antifungal, depending on how severe it is, as well as topical corticosteroids and antibiotics if you develop a cellulitis from the tinea. So this is for your fingernail fungi, and they have newer topical treatments out there. It's definitely hard to eradicate, especially on the toenails, because you're putting them in most moist, warm environments within the socks and shoes. So you just want to make sure you're educating your patients to really wash their socks, even wash their sneakers if they start to get really sweaty and wet, or just buy new ones depending on how bad it is, because fungi does live within these items. Okay, so tinea versicolor. Sometimes this is confused with vitiligo. It's chronic. It can be asymptomatic they write that, but although sometimes people do complain of burning and itching if it is severe, it is a superficial fungal infection. A lot of the times you'll see this with people who live in high heat, humidity area, because it increases the lesions if they're sweating a lot, if they're working out a lot, sports bras, that kind of thing definitely can lead to this. Any kind of Lyrica type products, clothing can hold sweat and fungi to the skin and can also lead to this. Exposure sometimes to sunlight can exacerbate it. The patches do not tan. So even if the patient gets a lot of these white patches on their skin, it takes years, even after treatment, and it seems to start disappearing, it still takes years for the patches to fade because they don't tan very easily. You diagnose it with an exam, Wood's lamp, or KOH. Again, you can use topical antifungal cream, oral antifungals, or topical shampoos. And by topical shampoos, a lot of the times the treatment for tinea versicolor is to take Selsun Blue, the anti-dandruff shampoo, and basically rub it all over these affected areas and leave it sitting there for like 10 to 12 minutes, a couple of times a day, twice a day for 7 to 14 days. And basically those particular patients will need ongoing prophylaxis with this type of shampoo because tinea versicolor is extremely difficult to eradicate. Sometimes it will disappear and go away, but it usually comes back. So again, it's all about prevention. After these particular patients exercise or are outdoors and sweating a lot, you want to encourage them to come in, shower, wash their skin, pat it dry, and definitely put on clean cotton clothing, clothing that can breathe as opposed to Lyrica type clothing. Okay, so fungi often present as pink to erythematous lesions with scaling. If you use a straight steroid on fungi, it can tend to bloom and even worsen the rash. So be very conscientious about that. Candidiasis, yeast, found in mucous membranes, GI tract, vagina, skin. Okay, cutaneous infections. We see a lot of thrush, both in infancy and older patients in their mouth, especially when they're on lots of antibiotics, right? We see that white coating in their mouth. Thrush is a form of yeast, okay? Diaper dermatitis in your babies, also a form of yeast. Oral candidiasis, thrush, again, yeast. Angular cheilitis, where you get those little fissures on the sides of your mouth, also a form of yeast. Vulvovaginitis or ballantitis, that's genital version of candidiasis. Web spaces of the fingers or toes, perineal area, under the breasts, in the folds, folliculitis, subungual candidiasis. Remember, these are all areas that tend to be very, very high risk for yeast. Warm, moist environments are where yeast like to survive. So your common sites are your armpits, your gluteal area in between your fingers, perianal or diaper region, under the breasts, under the abdominal folds, shaved areas, around the penis, obviously, the nails and the vagina, all high risk for yeast. So yeast candidiasis tips, or tips to prevent yeast. It's very frequent or difficult to eradicate candidiasis because it may be first presented that the patient is immunocompromised. So a lot of the times patients who are sick with any kind of infection, it doesn't have to be a long-standing history of disease. It could just be a random new infection, whether it's a urinary tract infection or anything that requires treatment can lead to a yeast infection. And when your immune system is down, yeast will grow. If you do have long-standing things such as HIV, diabetes, these are causes for frequent infections, which also can lead to a high risk for yeast infections. Higher risk people that will develop yeast infections or candidiasis are female patients in reproductive age, as well as African Americans. Obviously, immunocompromised patients, especially on steroids, are very high risk for yeast infections. Men with diabetes or uncircumcised penises, also high risk for yeast infections. Yes, men can get yeast infections as well. If a woman is diagnosed with a yeast infection, you also want to make sure you test her partner and treat her partner as well. Otherwise, they will continually have this yeast infection that will not go away because they'll continually give it back and forth to each other. Topical treatment with antifungals, they have antifungal powders, creams for drier lesions, ointments for intertriginous areas. We have oral formulations. We have diflucan, which is an oral antifungal. You want to make sure you're checking liver enzymes with those. We also have nystatin and clotrimazole troche, which is basically a lozenge. We have magic mouthwash for our thrush patients. But this is what Candida looks like. So here we have a fungal infection right under the breast. This is Candida, this is yeast, right? So we're looking at nystatin powder or nystatin ointment on this area. We also have an oral thrush right here. So this is where we would need magic mouthwash and possibly oral diflucan. Okay, another treatment, another disorder, psoriasis, which is relapsing disorder of keratin synthesis. This presents as well circumcised raised erythematous papules and plaques. Usually it's on the knees and the elbows. That's where you tend to see this. It's very plaquey looking. And if the patient has arthritis, the likelihood is psoriasis will complicate it between 10 to 20% of the time. It's less common in West Africans. It definitely is more common if you have a genetic background with any family history of it. You may need to use topical steroids, and it may require skin biopsy for diagnosis. So here are the silvery plaques of psoriasis. You see it in this person's ear. Again, it's more common on the elbows, knees. I've never really seen it on the chest personally, but I guess it does happen. And here's one on the scalp. I've never seen it there either, but it does. Actually, I have seen it on the scalp quite a bit. Not so red. Usually it's more grayish in color, but you do see it on the scalp. All right, erythema nodosum. It's a hypersensitivity reaction. It could be from meds, infections, pregnancy, strep. Usually it's erythematous lumps on the shins, the legs, less on the thighs and the forearms. This requires a skin biopsy, and it's usually from an underlying condition. So here's where you get these little nodules. Okay, erythema multiforme. This is a hypersensitivity reaction commonly triggered by infections. Target lesions, various stages, they may blister. There's not really any specific treatment except providing supportive care. Sometimes it can really make it hard to eat because they get the lesions in their mucous membranes. So just give them a lot of support and talk about, optional nutrition, milkshakes and stuff like that for those patients to give their mouth a break. Acanthosis nigricans, which is hyperpigmentation of the skin. It's occurring mostly in the folds of the skin and the axilla groin and the back of the neck. Usually you're going to see this more on your obese patients and a lot of the times on your diabetics, especially if they're having issues with insulin resistance. It presents as like this velvety dark spot. A lot of the times they have skin tags, but you'll see it right on the back of the neck, kind of like with skin folds. See, right there on the back, you'll see it a lot. And it's just like a darker area. So these are patients you want to talk to about managing their blood sugar as well as their weight. Okay, so rosacea, pityriasis rosacea, which is a viral rash, lasts 6 to 8 weeks. It's usually in young adults, mostly associated with HPV, any kind of virus, and certain medications. It's usually presents as a herald patch, a small oval lesion over the trunk, back, the chest for 1 day to 3 weeks. It may reoccur, it may have atypical presentations, pregnancy risk of marriage, pregnancy risk of miscarriage increases. You usually treat with lotions, topical steroids, and sometimes sunlight. And this is what it looks like, herald patches. See that? Okay, it also could have a Christmas tree pattern or distribution. Okay, we have actinic keratosis, and it's usually considered precancerous or an early form of cutaneous squamous cell. So you want to make sure that you definitely refer immediately if you see this. It's usually a scaly spot when you get some sun damage that develops. Follow-up depends on the therapy. So if you prescribe the liquid nitrogen, and it doesn't help, then we know we need to make a referral. So these are dark spots, seborrheic keratosis. These are dark spots. We call these age spots sometimes. They're harmless, watery dark spots. They occur later in life. 90% of adults over 60 years of age have them. They can erupt over after sunburn, and they can be difficult to differentiate from some forms of cancer. So you just want to be very conscientious about looking at comparing them to the other ones to see if they have some kind of malformation to them. You diagnose with a curette, cryotherapy, laser, or surgical remover. I mean, you can treat them like that. Now, skin cancers, super important. We have our non-melanomatous skin cancers and our melanomatous skin cancers. So we have basal cell, squamous cell, and malignant melanoma. And I really wanted to make sure you guys are grasping the difference between basal cell versus squamous cell. So I found this great little video to really help give you a visual and how to assess for skin cancer. There are the ABCs, so this is really good for you for your basic assessment, no matter what you're looking at in terms of any kind of skin disorders.
A stands for asymmetry. If you draw a line through the middle of this benign mole shown here, the two sides will match, meaning it is symmetrical. If you draw a line through this mole shown here, the two halves will not match, meaning it is asymmetrical, a warning sign for melanoma. B stands for border irregularity. A benign mole generally has smooth and even borders, as shown here. The borders of a melanoma, as shown here, may be uneven with scalloped, notched, or trailing edges. C stands for color variegation. Most benign moles have one or two evenly distributed colors. Having a variety of colors, including brown, black, white, red, and/or blue, may be a feature of melanoma. D stands for diameter greater than 0.5 centimeter. Although melanomas may be larger in diameter than the eraser head on your pencil, they may sometimes be smaller when first detected. The last letter, E, stands for evolution. In most cases, benign moles are stable over time. Be on alert when a mole starts to evolve or change in any way. When a mole is evolving, see a doctor. Any change in size, shape, color, texture, elevation, or any new symptom, such as bleeding, itching, or scabbing, may be a sign of malignancy.
So those are really basics to help remind you like what you're looking at, to keep it simple when you do look at any kind of abnormality at your patient's skin. So here we have non-melanomatous skin cancer. Sorry if I can't say that correctly. And in this particular case, we're talking about the basal cell carcinoma. It's fresh colored to SL pigmented lesion, and it's raised, shiny in appearance with pearly borders. Okay, and then we have our squamous cell carcinoma, which is roughened scaling area, readily bleeds, does not heal, and heaped up flake-like appearance. So this does not look normal. This does not look normal. So no matter what the severity of it is or what you may or may not think it is or isn't, the bottom line is these two things are abnormal looking and you need to refer them to a dermatologist for sure. Okay, so malignant melanoma. The risk is in light-skinned individuals, especially of Celtic descent, red hair, and family history. So your red hair, Irish, Celtic descent patients that have very, very fair, pale skin are at higher risk for this particular melanoma. There's often no symptoms other than presenting with a molar lesion that has changed color and is bleeding. So if they come in with an irritated mole that is bleeding, be concerned. You want to refer to dermatology and oncology for BRAF testing if necessary. It can metastasize and they may require chemotherapy. So remember, the sooner you refer, the better. Again, let's review the melanoma characteristics as you just saw in the video. A, B, C, D, E, asymmetry. If it's not symmetrical on both sides, if it's uneven on one side compared to the other. Border irregularities, meaning it's not like a real even circle. There's different borders that are irregular. The color variability within the lesion, meaning the lesion has a couple of different colors to it or shades. The diameter is greater than 6 millimeters and it's elevated, especially if it's recently raised. You want to watch for lesions of nails, hands, or feet, especially in dark-skinned individuals, Asians, and Asian Americans and African Americans. So here we are. This is irregular border, funny colors. These are all abnormal looking lesions. These all need to be referred, especially if they are raised, especially if they have raised suddenly. Okay, primary care management of skin lesions. You want to ask patients coming for routine CPE if they have any changes in appearance of size of skin lesions. You want to ask about the sunscreen usage, how much exposure they have to the sun. Do they have they had any burns, or have they have any family history of melanoma? You want to perform annual skin examinations of sun-exposed areas for those with a history of basal cell carcinoma or squamous cell carcinoma. You want to do a total annual skin examination for those with a history of multiple myeloma. And you want to make sure any concerning lesions are referred for biopsy to a dermatologist. And that's it, guys. This is a long PowerPoint. I hope this was super helpful in your understanding of dermatological conditions. And just remember, the most important thing is abnormal, really understanding and recognizing abnormal versus normal and when to refer out. Thanks and have a great week, and I'll see you next week.